It gives me great pleasure to introduce our next speaker, Dr. Callum Macpherson. Dr. Macpherson completed his PhD at Imperial College London. He joined the African Medical Research and Education Foundation in Nairobi and then moved to the Swiss Tropical Institute in Tanzania. This was followed by a year at the Liverpool School of Tropical Medicine. He then moved to Trinidad as Professor of Veterinary Parasitology at the University of the West Indies. He joined St. George's University in 1993 as Professor of Parasitology and Director of Research in the School of Medicine. He assisted with the creation of the schools of veterinary medicine and graduate studies. Today, he lectures in all 4 schools at SGU. He has been an invited speaker and has conducted research in over 50 countries. Dr. Macpherson is the founding director and vice president of the Windward Islands Research and Education Foundation, a charitable trust registered in New York and the UK, and an NGO in Grenada. Over the course of his career, he has supervised over 80 master's degree and PhD students in Kenya, Tanzania, India, the UK, Nevis, Trinidad and Tobago, and Grenada. In 2014, he was appointed to the Research Advisory Committee of the Caribbean Public Health Agency. He has served on many World Health Organization and Pan American Health Organization advisory committees. He has published over 140 peer-reviewed international journal articles and written or edited 5 books and over 30 book chapters. He has a wide diversity of research interests, but focuses on zoonoses and vector-borne diseases. I welcome Dr. Macpherson.
Thank you very much indeed. And I hope you can hear me. I'm going to share my screen. And my remit is to look at some of the outstanding research that has been done around the world. And to do this, we really have to take a leaf out of Winston Churchill's book, who said, the further back you can look, the further forward you're likely to be able to see. So let's go back, say 15, 16,000 years ago, when the air was clean, the food was organic and free range, and they got plenty of exercise. And yet their lifespans were only approximately 30 years. And the reason for this was a plethora of infectious diseases, mainly bacterial and viral, but also some parasites, perhaps malaria, and a few other protozoans. And over the millennia, we have been plagued by global pandemics. And this one is the latest. And I just want to mention that the pandemic caused by plague back in the 14th century wiped out between 30 and 70% of some villages in the UK and Europe, and profoundly affected societies. So these pandemics have had enormous effects on the development of human society. And then there was a Spanish flu back in the beginning of this century, in the last century, in 1918 to 1920. And this pandemic was due to H1N1. It was spread around the world at the end of the First World War by troops being moved to Europe and then back, and by trains and by boats, and reached all corners of the world. Most people that died from Spanish flu died from bacterial infections. It was before the advent of microbial therapeutics. And the people that died were in their mid-20s to 40s, very intact immune system, also the elderly, and it had a profound effect on the average lifespan in the US, where over 675 people died. It reduced the average age by 15 years. Fast forward, we've had a number of pandemics, the H1N1 pandemic of 2009, the smaller but important pandemic of the Ebola outbreak, and now the coronavirus 19, COVID-19, which is caused by SARS-CoV-2. We know very well the dendrogram of coronaviruses. There are thousands of species. It occurs in horseshoe-nosed bats in Southeast Asia, and most of them are not known to people, to humans yet, to science, but we know that a number of them cause, 4 of them cause a common cold. Unfortunately, we don't develop very good long-lasting immunity to the common cold, and these can circulate, so that's a little bit worrying. We have had also 2 smaller pandemics by coronaviruses. The first one is the severe acute respiratory syndrome, SARS-CoV-1, if you like, which was transmitted from bats to things like civet cats, which acted as intermediate hosts, and then got into the human population, and then there was human-to-human transmission. This occurred somewhere at the end of 2002, and in 2003, from Guangdong province, an infected individual traveled to Hong Kong, stayed at the Metropolitan Hotel, and infected 10 people. It's a very infectious virus, and these people traveled by air to many other parts of the world, and this pandemic began. These are the total number of cases. There's less than 800 people died. About 8,000 people got SARS-CoV-1. And I'd like to point out that this drop in cases occurred using just the non-pharmaceutical intervention measures that we have at for use in public health today. There was no vaccine. There is still no vaccine for this virus, and it disappeared before the end of 2003, and no human cases have been found since. The big difference between SARS-1 and SARS-2 that we're suffering from today is that the infectious period coincided with the onset of symptoms. So there was no asymptomatic transmission. So you became symptomatic, you were then infectious, you were isolated, and the contact tracing, etc., was taken place, and the virus was very quickly ended. It's important for us to know this is part of the history of SARS. There's another coronavirus, the Middle East respiratory syndrome, which also came from bats. Intermediate hosts are camels. It occurs mostly in Saudi Arabia, in the Middle East. About 2,500 people have been infected with this virus, and the mortality rate is approaching 40%. Fortunately for us, it has not spread a lot from the Middle Eastern region. Now to SARS-CoV-2, and this was a virus that probably emerged. We're not quite sure of the exact evolution, but we do know that it came from Southeast Asia, particularly part of China. And in that area, in the whole of Southeastern Asia, there are millions of caves with horseshoe-nosed bats, with SARS viruses. The guano from these bat caves is used for fertilizer on human food. They fly at dusk and dawn back to the caves, and they fly over human food. It might have originated from a wet market, or it might have originated, as some people speculate, from a lab, though that hasn't got a lot of traction by the scientists that really know about this virus. But it was described back at the beginning of this year and was picked up quickly by the press. And some milestones. So at the end of January, WHO declared a public health emergency of international standing. That was an important milestone. And then in the middle of March, on March the 11th, they declared it as a pandemic. The other milestone I just want to mention, besides the numbers, about 1.5 million people have died. About just under 50 million people have been confirmed with infection by diagnosis. But the WHO back in October said that 90% of the world's population was still susceptible to this infection. That to me was amazing, because that meant if they're suggesting 10% of the population from serological studies had perhaps been exposed already, that means 780 million people have been exposed to this virus by some estimates. So it does mean it's out there, it's spread so quickly, and it tells you how hyper-connected our planet is today. All corners of the world got this infection very quickly. So I just want to look at the macro picture, the macro epidemiology. You need institutions, you need the ability to make a diagnosis, diagnostic tests, to administer these sophisticated tests. Some countries don't have the same ability as others, and this allows you to look at the morbidity, the mortality, and the age, sex, and the other factors, the generation of vaccines and therapeutics. This is all done at the macro level, and different countries have different abilities to perform the macro epidemiological studies. And then looking at the individual level, we are understanding more every day. The volume of literature is huge. The individual responses, which are dependent on the heterogeneity of susceptibility of individuals, their immune status, their nutritional status. We know that micronutrients like vitamin D and like zinc are very important in this disease. Genetic differences, and then extrinsically, we know that the virus is changing. There are strains of it, and these strains moving forward are going to be very, very useful and interesting to look at the evolution of outbreaks, and a number of outbreaks are already being investigated that have different strains, and you can follow who got infected from where and when. So, excuse me, so these infections has resulted, and the clinicians, and I'm not going to dwell too much on this, you can look at various periods. There's the pre-infection period, which for public health experts, this is your field. This is the field that excites us most. This is the ability to prevent people from getting infected. And there are so many ways that we've got to look at this, not just wearing of masks and washing hands and physical distancing and testing, tracing, and isolation, but things like trying to make sure that the vulnerable people are not exposed, making sure that people with pre-existing conditions are protected, because we know diabetes, obesity, hypertension, cardiovascular disease predispose you to severe outcome from this disease. This is where the development of vaccines is going to play a very crucial role in preventing and slowing down this pandemic. And then going on into the viral replication phase, we can divide this up into a viral replication phase where different diagnostic tests come into play. This is where your PCR, your rapid antigen tests come into play. And then the inflammatory period, which we can turn into various clinical phases. And these phases have been shown to be incredibly important for the use of therapeutics in treating this disease. Our understanding of this inflammatory phase, where you get the cytokine storm, and how best to treat it, has dramatically lowered the mortality from this infection. And then there's a very curious group, the tail phase. The tail phase has got to be better understood, because this is those people who have recovered and made a good recovery, but they still have long-term problems of fatigue, mental fog, brain fog as they call it, and long-term sequelae. And so we can't underestimate the public health, the extent of the public health importance of this infection. In the United States, more than 40% of the people have comorbidities, such as diabetes, obesity, hypertension, etc. We do know that proportion of people who get infected, young people, older people, that they recover, but they have long-term cardiac issues. We also know that these long haulers, as they're called, who have long-term issues with having been infected, which lasts, and some people have been infected from the very beginning of this pandemic, and they're still struggling with the effects of infection. The insidious ethnic disparities that have been highlighted in many journals and many articles is something that public health experts really need to look at. We really need to examine this part of the pandemic. It's vitally important. We've made huge advances in diagnosis since the January the 10th, when the genome was released by the Chinese scientists. Immediately, PCR tests could be developed, vaccine candidates could be looked at, and so the advances made by sequencing that genome so quickly really helped in the diagnosis. So there's direct diagnostic tests, such as looking for the virus directly using PCR, using specific probes and primers, looking at rapid tests, looking at the antigen, doesn't amplify the virus, so less sensitive and specific. And then there's indirect tests looking at antibodies. And I just want to quickly remind ourselves of why these antibody tests looking at IgM, IgG fell into disrepute so quickly. And that's because of the properties of a test. So the sensitivity looks at, if you have a test, a patient with the disease, how many people does the test positively identify, and how many false negatives are there? That's the sensitivity of the test. Just as importantly is the specificity of the test, which rules out the disease. How many are true negative? And you've got a proportion of false positive individuals. Now, because these are ratios of the test, they're actually properties of the test, and they don't vary ever. What does vary is the positive predictive value. And this is where we ran into trouble with these antibody tests early on. The prevalence was low, and one false positive really impacts on the positive predictive value, which is the ability of a clinician who's making this test, the judgment of how positive is that test? How truly positive is it? And if you look at the prevalence, this ability, positive predictive value, varies with prevalence depending on the sensitivity and specificity of your test. You can put these calculations into a 2 times 2 table. I just had a look. If you look at 5% prevalence, using a test that's 95% sensitive and specific, you'd say that's a good test. But you need 5% to get to 50% positive predictive value. You might as well flip a coin to get the same positive predictive value. So you need higher prevalences, and as the disease gets more and more prevalent, so the predictive value gets better. Just to illustrate how important the specificity is for this, if you had 100% sensitivity and 85% specificity, you would still need around 15–20% to get a 50% positive predictive value, which is incredible. So the number of therapeutics is growing. which is wonderful. And those countries that have institutions that can develop these drugs and our understanding of the immune response, of the cytokine response, the immunomodulators, the anticoagulants, the corticosteroids, the interferons are all got a part to play, and they have to be introduced at the right phase, at the right time to make the maximum use of that therapeutic. Vaccines. Over 320 vaccine candidates are out there. They're in different phases. I just want to mention that some of them are in phase 3 trials now. And I want to talk more about the public health impact on how we've got to get the safety and efficacy of these vaccines right. I heard Dr. Ohl say 50% of people are saying they're not going to take a vaccine. That's because it became a little too politicized. What has been done that is right is that many governments are paying up front for these vaccines to be mass produced. So when they're ready, they're going to be ready to be out there and given to the population, frontline workers first, etc. So vaccines are going to be, hopefully, an important role. I just want to go back again into history. Smallpox probably killed over 300 million people during the times when the population of the world was less than 1 billion at various times in our history. And this was the first infectious disease that we developed a vaccine for. And I want to go back to Edward Jenner's time, back at the end of the 18th century. He was a country physician working in Gloucestershire, in rural Gloucestershire. He noticed that the milkmaids had beautiful complexions. Smallpox gave you pockmarked faces. And there was a song at the time, "Where are you going, my pretty maid? I'm going a-milking, sir. What is your fortune, my pretty maid? My face is my fortune, sir." And he put 2 and 2 together that if you're exposed to cowpox, maybe it protected you against smallpox. And he conducted using this cow, it's called Blossom. If you want to go and see Blossom's hide, the skin is hanging up in St. George's Medical School in London. And he took the pustules from cows and injected them. And he sent the report off after he had challenged the individual with smallpox, and the Royal Society rejected his paper. So he then did it again on his 1-year-old son, and they accepted the paper. It was quite an interesting time because there was a lot of opponents to his work. The people in the clergy of all stripes criticized it as blasphemy. The physicians of the day were losing a lot of money. They severely criticized Jenner and his work. And there was a group that was saying, mostly clinicians who were saying, if you inoculate bits of cow into somebody, you will get cancer. And by the way, the word vaccination comes from the Latin for cow is called vacca. And the process of putting cow bits into people is called vaccination. And so there was an enormous amount of opposition. If you look at the therapeutics, the bloodletting, and that was used back then, really didn't have much effect on the mortality compared to the 1970s, when smallpox, we still couldn't effectively treat it. And what about this? The celebrities of the day, like George Bernard Shaw Wallace, all came out against vaccination. Anyway, Jenner persevered. He had to publish his paper himself. So this was one of the first examples of a self-publicized book on the process of vaccination. And it got wide notoriety. He was very adamant. He really pushed this. And it eventually got wide recognition by many leaders around the world. A statue of him was placed in Trafalgar Square, where all the heroes of the UK are placed. And the physicians of the day were so adamant that he should not be part of the heroes of the UK. They campaigned to have his statue removed. And in the middle of the night, they took the statue of Edward Jenner and they placed it in the Italian Gardens in Kensington Gardens in London, where you can go and see him. He's very fortunate. There are very few pigeons in the Italian gardens compared to Trafalgar Square. So he's there in all his splendor and is recognized. So we do know how to control this disease. There are many non-pharmaceutical intervention methods. We know that there are many countries in the world that have done a fantastic job at keeping this virus at bay. And every time it raised its head, like in Australia, New Zealand, South Korea and Taiwan, Vietnam, in many Thailand, they have done a fantastic job at preventing this viral spread. So we have had many advances in science, and I just want to highlight that with so many clinical trials, all pre-print publications, many publications, it has led to a plethora of meta-analyses, papers, which take little studies here and there and everywhere else and compare them. And in a meta-analysis, you get a really good understanding of the point of that part of the investigation. We've also understood the molecular biology of this virus very quickly, very well. We've understood the pathophysiology of the virus that it causes. We have developed many electronic apps. We got 3D printing of things that we couldn't get. And the apps have been used in contact tracing. They're used for immigration purposes. They're used for quarantine. They really a fantastic development. And for us in this conference, I don't know how many countries are represented here today, but many, and many people in different parts of the world, all tuning in, the amount of information, and us in education, in the Department of Public Health and Preventive Medicine, we can have classes online, really effective, and we're improving, and there's so many platforms today. There are no excuses for not trying to get this pandemic under control. We don't need to wait for a vaccine. We don't know if a vaccine is going to be safe, effective. We just don't have that data yet. The scientists are working on it very hard, and I'm sure, hopefully, one is going to come along, but then the population have to accept it and hope that they will accept it in the numbers that we'll need for herd immunity so that the R0 will go down below 1 and we will eliminate this virus. I just want to highlight the public health differences that have just taken place in the United States in the election, where you've got one program which had no social distancing, no masks. This is not me politicizing anything. I'm looking at it from a public health viewpoint. And another candidate using masks, social distancing, everyone in their cars, hooting their horns. The two differences could not be more stark. And I just want to say that the effects of these campaigns is going to have an impact on individuals for the next weeks, the next months, perhaps for a lifetime. And we have to be careful, and we mustn't ever forget that it is human behavior that is often forgotten in disease control programs. Thank you very much.